you.
Bye.
Thank you, Charlene.
All right, I'm just going to give it a couple more seconds. We got 14 participants, so I think that's probably about it. It's about a third of the people that are attending the conference. So. All right, so my name is Chelsea. I'm a nurse practitioner at the East Carolina University HTC in Greenville, North Carolina. Today, I'm going to be talking about von Willebrand disease, some basic introduction to it, and then just some updates in the diagnosis and management recommendations that came out in February of this year. Okay, so for today, we're just, like I said, going to do a brief introduction to von Willebrand disease, talk about the subtypes, how they're inherited, and then jump into the actual guidelines. And then at the end, there can be questions and answers, but if you have questions, feel free to try to ask them. Like I said, I'm not super savvy on Zoom. So if somebody sees like a question in the chat and I don't seem to notice it, if anyone wants to unmute themselves and just ask, that's totally fine. I don't necessarily consider myself an expert, but I've definitely learned a lot preparing for today. So just von Willebrand disease 101. It is the most common inherited bleeding disorder. There are acquired types of von Willebrand disease, but we're going to be talking about the inherited forms today. So it's estimated to impact about 1% of the population, although it's probably underdiagnosed, so it's a little bit difficult to say how much it impacts if we're not really sure that everyone's being diagnosed. Because of the inheritance pattern, it's thought to affect men and women equally, but it's often more diagnosed in women because they end up having more bleeding issues with menstrual periods and childbirth. So von Willebrand disease can be one of two things. It's an issue with your von Willebrand factor. It's either you're not making enough or you're making enough and it's defective. Typically, the symptoms associated with von Willebrand disease are epistaxis or nosebleeds, oral or mucocutaneous bleeding, gum bleeding, easy bruising, prolonged bleeding from cuts, excessive bleeding during or after childbirth, and menorrhagia or heavy and prolonged menstrual periods. So what is von Willebrand factor and what does it do? It is a large glycoprotein. It's synthesized and stored in the endothelial cells and the megakaryocytes, which are the precursors to platelets, which is good because it gets activated by breaks in endothelial cells and has to attach to platelets. So it's definitely stored in the right place. There are three functions of von Willebrand factor. It, on one part, binds to exposed collagen. So at the site of a vascular injury, collagen gets exposed and it will bind there. And then on the other side, it binds to the glycoprotein 1B or GP1B component on the platelets. So it kind of holds to the collagen and then holds to the platelets, pulls them together to try to create the platelet plug for primary hemostasis. And then the other job of von Willebrand factor is to bind to and protect factor VIII. So it pulls together the platelets to create that primary platelet plug, and then it carries factor VIII and protects it from being broken down so that factor VIII can start influencing the intrinsic pathway and get actual clot formation. So quantitative versus qualitative defects, quantitative, of course, being not enough, and qualitative being it doesn't work correctly. Most of von Willebrand disease patients have type 1. So primarily it's a quantitative defect. About 3/4 of the people who have von Willebrand disease have type 1. There's either very mild to no bleeding. They can be severe bleeders, but typically that's considered a mild bleeding. Type 2 and all the subtypes of type 2 are all the qualitative defects. So they typically make enough von Willebrand factor, although sometimes they don't make enough and it doesn't work. But typically that's just, it doesn't do one of the 3 jobs that it's supposed to do. In type 3, you make little to no von Willebrand factor. It is definitely the most rare form of von Willebrand disease, about 1 in a million, and it typically presents more like a mild hemophilia. All right, so inheritance-wise, most of the subtypes are autosomal dominant, meaning you just have to inherit one abnormal gene, and then you have the disease. Subtypes 2N and type 3 are autosomal recessive, meaning you do have to inherit a gene from both parents in order to have the actual disease. Otherwise, you're considered a carrier. All right, as we said, type 1 von Willebrand disease is the most common subtype with autosomal dominant inheritance. It is typically manifested with nosebleeds, bruising, and oral or mucocutaneous bleeding. There are not severe and deep bleeds with type 1 von Willebrand disease the way you see in type 3 or some of the hemophilias. So there should not be muscle bleeds or bleeding into the joints. For women, it is definitely associated with heavy and or prolonged menstrual periods and excessive bleeding with childbirth. And we also know that there's an increased risk for miscarriage. Typically, type 1 von Willebrand disease is treated with DDAVP or Desmopressin, which encourages the body to release von Willebrand factor from the endothelial cells into the circulation, as well as antifibrinolytics, which help clots stay in place and not break down as quickly. All right, so the type 2 subtypes are the kind of the most interesting ones of von Willebrand disease. Type 2A is typically associated with mild to moderate bleeding. It's a deficiency of high molecular weight multimers, which are the most effective multimers or kind of size of von Willebrand factor at doing the jobs that it has to do. That deficiency can either be impaired synthesis, so the body's not making enough of those large multimers, or the multimers are kind of more prone to being broken down and cleaved by the enzyme ADAMTS13. The decrease in high molecular weight multimers, leads to decreased platelet adhesion, but there's no issue with factor 8 for this one. This is just an issue with the von Willebrand factor not being able to hang on to the platelets. Type 2B is for a lack of high molecular weight multimers because of enhanced affinity for the platelets. So essentially type 2B it's overactivated for platelets. So it binds to platelets excessively without collagen exposure, and then those get broken down. So typically type 2B patients will have some component of thrombocytopenia, which often gets worse with any kind of physiologic stressor, such as surgery, pregnancy, infection. So for those patients, we don't want them to release more von Willebrand factor because their von Willebrand factor will just bind to more platelets. So we definitely have to treat this one differently. So typically we treat it with von Willebrand factor and factor 8 concentrates. Because like I said, if we use DDAVP, which works for type 1 and some other subtypes, it will put out more von Willebrand factor, bind to more platelets, and then the platelets will drop even further. For other problems in von Willebrand type 2B patients, such as uterine bleeding, we need to do like IUDs, hormonal therapies, other approaches to target that issue. And we can also do antifibrinolytics, which will hold the clots in place, or even topical agents to help stop bleeding that are applied topically. All right, so type 2M is a qualitative defect in von Willebrand function as well, but it has normal multimer distribution. It's either an issue with the binding activity at the platelet or collagen, or sometimes both. So it's very similar to type 2A in that there's an issue that they don't bind to platelets as well, but it's a different root cause. It's not a multimer issue. It's a mutation that causes problems with binding. This one is typically associated with mild to moderate mucocutaneous bleeding, but not to a severe bleeding. And then type 2N is also called type 2 Normandy. It binds to platelets with no issue. It binds to collagen with no issue, binds to platelets with no issue, but it has very little affinity for factor VIII. So von Willebrand factor not only moves factor VIII, it protects it from being broken down. So when the von Willebrand factor is not protecting the factor VIII can become deficient. This one is an autosomal recessive inheritance pattern. So you do have to get 2 genes, one from each parent, to be able to have a type 2N von Willebrand disease. So what you'll see is that the factor VIII and von Willebrand antigen ratio is low. So there should be kind of an equal amount of factor VIII and von Willebrand factor because they typically work together. So what you'll see is there's a lot more von Willebrand factor than there is factor VIII. But then when you test the von Willebrand factor to see if it works, if the von Willebrand factor itself can activate, it can. It's just an issue of how it binds with factor VIII. So you can read here is associated with different mutations. Desmopressin can improve that because we give the desmopressin, von Willebrand factor is released from the, I'm sorry, I lose words sometimes, but it's released and it can improve the factor VIII binding because of the sheer quantity, but it doesn't typically last for very long. One thing to note is that in this type 2N, the factor VIII typically normalizes itself by the end of pregnancy, and you don't actually have to do anything to help prevent bleeding at childbirth time. All right, and type 3 is the most severe and the rarest form. Like I said before, it's about 1 in a million patients with that have type 3 von Willebrand disease. It is very similar to a hemophilia A. It is also autosomal recessive, meaning you have to get that gene from both parents. So these patients make little to no von Willebrand factor. And because the von Willebrand factor is not there to carry and protect the factor VIII, the factor VIII levels also drop significantly. And so with no von Willebrand factor, you don't have the means to make that primary hemostasis platelet plug. And then you don't have the ability to carry factor VIII, it doesn't get activated. So then that secondary part of hemostasis also doesn't work. So these folks can have symptoms very similar to hemophilia with spontaneous muscle bleeding and joint bleeding. Typically the first line treatment for these patients is factor replacement. So plasma derived von Willebrand and factor VIII concentrates. Depending on the patient and their phenotype, you can just use it on demand for active bleeds. We definitely use it for prophylaxis before surgery or procedures where there could be bleeding. And then some patients are on a long-term prophylaxis, either in response to joint bleeds or just as a preventative measure. All right, so that is our kind of brief introduction into von Willebrand disease. I'm not going to waste too much time on this slide. It's a lot of words, but pretty much it's telling you that these guidelines for von Willebrand disease were a collaborative effort between ASH, the International Society for Thrombosis and Hemostasis, the National Hemophilia Foundation, and the World Federation for Hemophilia. So a lot of different groups came together and they did extensive discussion about kind of how they wanted to do it, why they wanted to do it. They wanted to make sure that it was evidence-based recommendations. They put out a survey for 6 weeks in 2018, which got a lot of responses and a lot of comments from both healthcare providers and from patients, kind of an equal amount. So that was nice. It wasn't just driven by providers. There was also a lot of patient involvement. And then the rest is just kind of their meeting schedule. They had 2 different panels, one panel for the management of von Willebrand disease and one for the diagnosis of von Willebrand disease. And so those were 2 completely separate groups. And even when you read the recommendations, they're presented just slightly differently. You can definitely tell it was 2 different groups. Each panel, though, did include clinicians from different, I'm sorry, I'm just bad at words, different kinds of clinicians. So we had hematologists, there were gynecologists, dentists, internists, and there were also multiple patients on every panel. So it wasn't just being driven by the people taking care of the patients, it was also being driven by the patients themselves. And while they were meeting and looking and trying to create these guidelines, they went back to the survey often, made sure that they were actually answering the questions that people wanted answers to. And they were using kind of tables and this evidence to decision framework. So you can look online and see every study they reviewed, how they determined if it was important or not. Like pretty much you can follow their entire decision pathway and understand how they came up with each guideline. There are 2 kinds of recommendations: strong recommendations and conditional recommendations. I put these little characters to make it easier to identify. So a strong recommendation is something that most patients would want. Only a small portion would not. And clinician-wise, it means that most patients should receive that course of action. As far as if policymakers are looking at the recommendations, it's something that most likely can be adapted into policy because it would be true for most patients. Our conditional recommendations, they'll say we suggest, whereas in the strong recommendations, they say we recommend. So for these suggested recommendations, from the patient perspective, it means the majority of people would want it, but there were many who would not want that course of action. For clinicians, it means you need to be prepared to have a conversation with the patients about their own values, and not that we wouldn't have those conversations anyway, but it's definitely more of a person-to-person decision, not a most people actually want this. As far as policymakers, they really shouldn't be making policies on conditional recommendations. They would need to debate and involve everybody, the stakeholders, to make those recommendations. So anywhere you see a little man lifting weights or woman lifting weights, that is a strong recommendation. And anywhere you see the little conversation bubbles, that's a conditional recommendation. It means that really need to have a conversation with your patients about that before you decide what's best. So we're going to jump into the diagnostic guidelines. In total, there are 11 recommendations. They talk about the role of bleeding assessment tools, or BATs, in the assessment of patients, diagnostic cutoffs for type 1 and type 2, how to approach certain situations with type 1, and then the role of genetic testing versus phenotypic assays for some of the type 2 subtypes. They do not discuss it all in the diagnostic guidelines: platelet type von Willebrand disease, acquired von Willebrand disease, or type 3. Does anybody have any questions before I start? Okay, great. All right, so for the bleeding assessment tools, the 2 questions they were asking were, for patients with suspected von Willebrand disease, should a BAT or non-standardized clinical assessment be used to screen for von Willebrand disease? The second question being for patients, especially men and children, suspected of having von Willebrand disease with a negative or normal bleeding score based on a BAT, should they receive blood testing or should they not receive blood testing? So it is a strong recommendation that patients with a low probability of von Willebrand disease seen in the primary care setting, the panel recommends using a BAT tool as the initial screening to determine if they need actual blood testing. So pretty much that just means if they probably don't, but you're not really sure, use one of these validated tools. There is something to note that the tools are typically used in adult women. So the validity of the BATs is the strongest for adult women, but what they're referring to is kind of anybody, men, women, children. Should we use a BAT to help determine whether or not we should move on with blood testing? And also note that this is typically in the primary care setting. Recommendation 2 is a conditional recommendation. They say for patients with an intermediate probability of von Willebrand disease, so ones that have already been referred to the hematologist, they say you don't need to use a BAT to determine whether or not they should do additional testing. If you've already gotten to the hematologist, you probably need additional testing if the first step was to look at a BAT and see if they needed a referral. It's really just a screening test. So once you get into the hands of the hematologist, you're most likely going to get some blood testing. Recommendation 3 is a strong recommendation. So for patients with a high probability of von Willebrand disease, so maybe they have a family member with it, and they've definitely already been referred to the hematologist, the panel recommends against using a BAT to decide. Again, these patients have a high probability of having von Willebrand disease, so we shouldn't exclude them from testing just based on the results of a screening test, which realistically you would expect to indicate that they should have testing anyway. All right, the next focus is for assays of platelet-dependent activity for von Willebrand factor. So for patients suspected of von Willebrand disease, should you be using a von Willebrand factor Ristocetin co-assay or the newer assays that reflect platelet binding activity, such as von Willebrand to GP1B and either the M or the R? Should those be used to diagnose von Willebrand disease? As a conditional recommendation, the panel suggested the newer assays, which are the GP1B-M and the GP1B-R, over the Ristocetin cofactor, which was the classic test that was done to assess platelet binding. The caveat there is you need to use a lab that does that test and knows how to interpret that test. So if you're working with a lab that really only knows how to do the Ristocetin cofactor, then use it. But if you have the option of doing the more specific and newer platelet binding tests, they do suggest that those are the ones you use. All right, for patients who have been diagnosed with von Willebrand disease, but have aged and now have normal von Willebrand factor levels, should you reconsider the diagnosis or should it be removed altogether? As a condition recommendation, the panel suggested reconsidering the diagnosis as opposed to removing it. Typically, the panel worked under the assumption that the first diagnosis was actually accurate. We know that in patients with kind of borderline activity levels, those levels can be elevated by certain stressors. And so sometimes it's a little bit questionable to begin with. So they are definitely working under the assumption that the first diagnosis was correct. We do know that certain things, like I said, can increase the factor levels, but having an increased factor level doesn't always stop your bleeding symptoms. So if somebody has a normalized level, that doesn't mean they didn't have von Willebrand disease, and they don't necessarily still not have von Willebrand disease. So it shouldn't just be removed as a problem. Okay, now for type 1s, for patients with an abnormal initial von Willebrand screen, so either low von Willebrand factor and or platelet activity, if they're suspected of type 1, what should the diagnostic cutoff be? Should it be less than 0.3 or 0.5 international units per milliliter? This is a strong recommendation. They recommend that the panel uses less than 0.3 regardless of bleeding, and a level of 0.5 if they have history of bleeding. So pretty much if they present and they sound like they have von Willebrand disease and they have a 0.45 international units per milliliter, we can diagnose them with von Willebrand disease. Now, if you have no history of bleeding, but somehow you have von Willebrand factor less than 0.3, you also have von Willebrand disease. Make note again that von Willebrand factor is an acute phase reactant, and so in certain situations and responses to stimuli, they should be performed at baseline health, not during those stressors or illnesses. All right, for type 1C, type 1C is not technically a formal diagnosis, but clinicians know it's type 1 where they have a fast clearance of von Willebrand factor. So for patients suspected of type 1 with an increased clearance, should the ratio of propeptide to von Willebrand antigen or desmopressin with a 1 in 4 hour post-infusion blood work be used to confirm increased von Willebrand clearance? So they actually recommend against using the von Willebrand propeptide to antigen, and rather using a desmopressin trial at 1 and 4 hours post-infusion to confirm increased clearance. So pretty much what they're saying is the stymate challenges that we were doing when stymate was available, you should be doing a stymate challenge, giving them the desmopressin, rechecking at 1 hour and at 4 hours, and seeing if they have a response at 1 hour and then it drops significantly by 4 hours. That's really how they would be identified, not with the von Willebrand factor propeptide antigen ratio. All right, for patients with an abnormal initial von Willebrand screen and suspected of type 2, should a platelet-dependent von Willebrand factor antigen ratio cutoff be less than 0.5 or higher cutoff at less than 0.7 to confirm their type? Strong recommendation. They said they're suggesting against using the cutoff of less than 0.5 and using a more liberal cutoff of less than 0.7 for type 2 von Willebrand patients for A, B, and M, not for N, which is a little bit different, for those patients with an initial abnormal von Willebrand screen. All right. For patients with type 2A, 2B, or 2M in need of additional testing, should we be testing multimers or von Willebrand collagen binding or von Willebrand antigen ratio? Remember, for the type 2A, they have decreased platelet binding because they have a decrease in those high molecular weight multimers. In type 2B, they have the increased platelet adhesion and then thrombocytopenia. In type 2M, they have just decreased platelet interaction for either collagen binding or platelet binding reasons. As a conditional recommendation, the panel suggests either the multiple analysis or the collagen binding antigen ratio. So they say whatever one you can do is fine. Most of the time, the collagen binding assay is used for type 1 or type 3, which is known to be a surrogate of the, type 1 and or 3 collagen, which is a surrogate for the high molecular weight multimers of von Willebrand factor. All right. For patients suspected of type 2A or 2B, should low dose ricecidin induce platelet aggregation or target genetic testing be used to diagnose type 2B? Conditionally, they suggest genetic testing over that low dose RIPA to diagnose type 2B for patients suspected of type 2A or B in need of additional testing. So pretty much to weed out the type A's from the type B's. Ideally, you would do some genetic testing, but again, that's a matter of what's available to you. If the low dose RIPA is all that's available, that's better than nothing. All right, for patients with type 2N or suspected type 2N in need of additional testing should use von Willebrand factor, factor 8 binding, or targeted genetic testing. And remember, the type 2N is the kind that doesn't have a good affinity for factor 8, so it doesn't bind to factor 8 well, and this is the one that behaves more like hemophilia A. As a conditional recommendation, the panel suggests either one, using either von Willebrand factor and factor 8 binding or targeted genetic testing. So again, just like before, what is available to you is what you should use. If both are available, you can choose either one. All right, so that is all of our recommendations on diagnosis. I know it was really fast. All of this stuff is available, and all of the data they use to make these recommendations is all available online. I'll make sure you get that information at the end. Does anyone have any questions right now? Okay. So next, we're talking about the guidelines on management. So this was a separate panel of folks, again, clinicians and patients, that agreed on 12 recommendations, and they also talked about some future research priorities. These guidelines are making recommendations on prophylaxis for recurrent and frequent bleeding, Desmopressin trials to determine therapy, use of antiplatelet agents, anticoagulation therapy, and target factor, both von Willebrand and factor 8 levels for major surgery, strategies to reduce bleeding for minor surgeries or invasive procedures, and the management options for things like heavy menstrual bleeding, neuraxial anesthesia or epidurals during labor and delivery, and the management of postpartum bleeding. All right, I'm going to say this, all of the recommendations on management are conditional. So none of them have such great evidence that they're strong recommendations. As far as prophylaxis goes, in patients with von Willebrand disease and a history of severe and frequent bleeding, the panel suggests using long-term prophylaxis versus no prophylaxis. Pretty much meaning, don't worry about what their diagnosis is and determine if they need prophylaxis. Look at how they bleed. And if they are people who bleed severely and frequently, then we need to consider putting them on prophylaxis. Of course, we need to reassess that periodically and make sure that they still need to be on prophylaxis if they've placed on it, or vice versa. We can't look at them once and say, oh, well, you don't need prophy, and then never reassess it. It should be reassessed regularly. As far as desmopressin challenges or stymate challenges in administration, the recommendation is in patients for whom DDAVP is a treatment option, so typically the type 1 patients, and who have a baseline von Willebrand factor of less than 0.3, so the more severe the more severe lab values at least. The panel suggests performing a Desmopressin trial and treating based on those results over not doing it and giving them tranexamic acid or factor concentrate. So Desmopressin is kind of one of the foundational parts of treatment for our type 1 von Willebrand patients. And so this is a pretty straightforward recommendation that we should keep using Desmopressin. The second recommendation as far as the Desmopressin goes, that for those patients, they suggest against treating with Desmopressin in the absence of a Desmopressin trial. So meaning if you haven't tested Desmopressin in that patient, you shouldn't use it in an emergency situation because you don't know that it's going to work. Von Willebrand disease is very phenotypically variable, meaning you can't look at what the numbers say and know how they're going to behave. You have to treat each patient individually and see what works for them. So they conditionally suggest against using Desmopressin if we don't know that it works. I'm not going to read through all of this, but essentially it's just details of what we talked about. The only thing I would say is the type 2 patients typically don't respond to Desmopressin because their von Willebrand factor doesn't work. So releasing more von Willebrand factor that's broken is not necessarily going to stop bleeding in the majority of the type 2 patients. All right, antithrombotic therapy. So Recommendation 3 for the management of patients with von Willebrand disease is that in these patients with von Willebrand disease and cardiovascular disease who require treatment with antiplatelet agents or anticoagulation agents, the panel suggests giving them the necessary antiplatelet and anticoagulation treatment over no treatment. Meaning you have von Willebrand disease and you also have a very high risk for stroke and the doctor wants to put you on aspirin. Their recommendation is that you should go ahead and get started on the aspirin, that the increased risk for bleeding is probably not as significant as your stroke risk being ignored. And of course, reassess that bleeding risk throughout the time that the patient's on an antithrombotic medicine. For major surgery, and I meant to put in here kind of the definitions they gave for major surgery and minor surgery, and I forgot. So that is also available in all the documents, and I'll try to get that information out on an email at the end. The panel suggests targeting both factor VIII and von Willebrand factor levels to greater than 0.5 for at least 3 days after the surgery. So remember, we're saying less than 0.5 for anybody, bleeding history or not, is a patient that they would recommend diagnosing with von Willebrand disease. So we need to keep their factor VIII and their von Willebrand factor, because they work together, you need to keep them both into a normal range for at least 3 days after surgery. The panel does suggest against using only factor VIII as a target, which makes sense because if you have a von Willebrand deficiency, you need von Willebrand as well, not just factor VIII. The factor VIII won't work without the von Willebrand factor. Let's see, when it's possible to keep both trough levels above 0.5 for at least 3 days, you should. And I guess that's kind of the same as what we just said. And then depending on the type of surgery, if it is like a major bleeding risk surgery, you can also extend the length of time that you want to keep their von Willebrand and factor VIII levels into that normal range. All right, so for minor surgery and invasive procedures, the panel suggests increasing the activity levels to greater than 0.5 with desmopressin or concentrate, with the addition of tranexamic acid over raising the von Willebrand factor levels with desmopressin or factor concentrate alone. A lot of words to say. You should use something to increase their factor levels in addition to an antithrombotic versus just increasing their factor levels alone. The panel also suggests giving tranexamic acid alone over increasing the factor activity levels to 0.5 with any intervention in patients with type 1 who have a baseline activity greater than 0.3 and bleeding phenotype that is mild, undergoing mucosal procedures. So for the patients who already have a pretty decent von Willebrand factor level, and they really aren't kids who, or kids, adults too, people who bleed very frequently, if they're getting maybe a tooth pulled, you can just do the antithrombolytics. You don't have to do any of the other interventions. We just need something that's going to hold that clot in place a little bit longer once it's there. But again, remember, these are all conditional recommendations. So if you have a patient that, or you are a patient, person that has von Willebrand disease that's having some kind of minor surgery invasive procedure, know that most people would be okay with just the tranexamic acid or Amicar, but if you feel differently, that's okay. Same kind of information. Von Willebrand type 3, of course, you need a factor concentrate because you don't make enough, so you're going to need it. Again, so our type 2s, remember, we don't usually use desmopressin for them. So in order to get their factor levels where we want them, we will have to use a factor product. All right, so now the rest I think is GYN related. As far as heavy menstrual bleeding, the panel suggests either using hormonal therapy, so birth control pills, combined oral contraceptives, meaning progestin and estrogen, or an IUD over tranexamic acid, or tranexamic acid over desmopressin to treat von Willebrand, women with von Willebrand disease and heavy menstrual bleeding who are not trying to conceive. that's pretty straightforward. You should use a hormonal therapy or tranexamic acid versus desmopressin for heavy menstrual bleeding, which makes sense. The desmopressin doesn't last for very long. The panel also suggests using tranexamic acid over desmopressin in general for patients who do wish to conceive. So obviously we're not going to have patients who are trying to have a baby on birth control pills. This is not to say that patients who are on birth control pills can't have tranexamic acid. They can definitely do a dual therapy if they need that. And once again, don't use DDAVP in patients with type 2 von Willebrand, especially type 2B, and it's not effective in type 3. Also note that if you put an IUD in a woman with a bleeding disorder, they are likely to have heavier bleeding that first couple of months after placement, and you're likely going to need additional intervention. Like if they didn't need tranexamic acid or Amicar before, they'll probably need it for that amount of time. All right, neuraxial anesthesia or epidurals and spinals. For women with von Willebrand disease, for whom want neuraxial, I can't say that word, who want epidurals or spinals during labor and it's deemed suitable as from a GYN perspective, the panel suggests getting the von Willebrand factor activity level from 0.5 to 1.5. That doesn't need to be greater than 1.5 for that anesthesia to be appropriate. Previously, von Willebrand factor recommendations were greater than 1.5 and may be appropriate in some situations, but for most, the 0.5 to 1.5 is going to be appropriate. Of course, this isn't telling women they have to get an epidural or a spinal. It doesn't address the appropriateness of those interventions from a GYN perspective. This is purely from a bleeding perspective. Also, they should maintain a level at least greater than 0.5 while the epidural is in place and for 6 hours after removal. So we don't want to get their factor levels appropriate, put the epidural in and then forget. All right. Postpartum management. The guideline suggests the use of tranexamic acid over not using it in women with type 1 or low von Willebrand levels. Sometimes it applies in type 2 and type 3 during the postpartum period. So tranexamic acid can be used, can be given through the IV or orally. The dose would be 25 mg per kg 3 times a day for 10 to 14 days. So the patient, say, doesn't have an epidural, has a vaginal delivery that goes well, you should still have them on tranexamic acid for 10 to 14 days after delivery. Patients should be kind of counseled on any kind of tranexamic acid risk for breastfeeding, which it's safe and actually breastfeeding in conjunction with it can help reduce the bleeding. So that's good news. That's it. That's all I have. I guess I have a little bit more time than I thought I would, but does anyone have any questions?
No questions, thanks.
I guess I have a question. My one thing that I was thinking about through this talk was how do the medications that people take with von Willebrand's type 1, do they affect the fetus at all during pregnancy or breastfeeding, or is that just something that doesn't get into their system?
Do you mean like the desmopressin and tranexamic acid?
Yeah, that kind of stuff, or like stymate. I know stymate's not available right now.
Yeah, so sorry. So the desmopressin and stymate are the same.
Oh, yeah. Sorry.
No, it's fine. I should have been clearer about that. I could lie to you and tell you an answer, but I honestly don't know the answer to that question. But I definitely should know the answer, and I'm going to find out for you. I know tranexamic acid is okay, but the desmopressin, in my gut is telling me probably is not as good of an option, but I don't know off the top of my head. I can try to find that out for you though, okay?
Yeah, thank you.
Mm-hmm. Anybody else?
Very thorough. Thank you.
So I have an answer to your desmopressin question. It's actually category B on the pregnancy risk. So it can be used for women when they're pregnant. It doesn't seem to be contraindicated at all. The same, there haven't been any reports of issues for breastfeeding parents, breastfeeding mothers.
Okay, thank you for finding that out.
Mhm.
And if there aren't any questions, any other questions, y'all can press the leave room and then come back to the main room. I know Jillian just has some announcements. Thank you very much, Chelsea, for doing this.
Yeah, it was fun.
And I'm gonna go figure out which laptop in the other room you're on so I can stop the recording.
Okay, all right, thank you.
Thank you, Chelsea. Very thorough, very
Good.
thorough.
Thank you.